Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much, Nurhan, for an icon for this video, which sum up the program, the point of care ultrasound in acute care settings. It's my pleasure to meet all of you today in this live webinar as part of our online fellowship program, the point of care ultrasonography advanced critical care module. As we used to do, every 4 weeks, we have the 5th week for live webinar. And the idea of the live webinar, as we said before several times, that this is the chance of the fellows to meet the faculty, to ask their own questions about the material they had in the previous weeks, and to bring their cases for presentation, and we can have discussion among the faculties, the other fellows, and we share the knowledge and experience. Tonight, as I said, this is the 2nd live webinar in the 2nd advanced critical care module. We have emergency module, and this is the live webinar will be on 10th of June. Today, we decided to cover a topic which is not covered in the material of the advanced module, which is the prediction of fluid responsiveness, both in spontaneously breathing patients and in controlled mechanically ventilated patients. A very important topic would answer the question of when to give and when not to give the IV fluid, because everyone knows that a fluid is a drug that we have to deal with as it requires to be dealt with cautious, because if you give it unnecessarily, you jeopardize your patient's care, definitely increasing the morbidity and mortality. This webinar will be having two eminent speakers actually tonight. Dr. Muhammad Abu Ragif will speak about the prediction of fluid responsiveness in spontaneously breathing patients, and the focus will be on the point of care ultrasound. And Dr. Abu Ragif is a well-known emergency physician in Sweden, and he is an editor and chief of Sweden Emergency Learning and Mastery, EMSCC, and he is also the chair of Critical Care Committee in the Swedish Society of Emergency Medicine. And we had the pleasure to know Dr. Abu Ragif, and he is one of the board member in our program. The second, the speaker of tonight, who is a friend of mine also, Dr. Olusegun Olusiana, and I'm always pronouncing the name maybe with difficulty, and I apologize for this several times before. But Dr. Shigon, which he likes to be called, is a consultant intensivist here in Barts Health NHS Trust, University of Southampton, UK. And he will speak about, as I said, the second half of this tonight presentations, which will be about the mechanically ventilated patients, when to give and when not to give using the point of care ultrasound, the fluid. The third interesting part of this meeting tonight will be a case presentation by one of our fellows, Dr. Shamin Wirisikara, and he is a consultant intensivist also, and he is a fellow with us in the point of care ultrasound advanced module. Just before I go ahead and give the phone to or the mic to Dr. Muhammad Abu Ragif to start, who is going to have 20 minutes to go through the topic, and then Dr. Sigon will have 25 minutes, and Shamin will have 10 minutes, and then we'll have the discussion. So keep your questions or text them, write them in the Q&A. And Dr. Hisham Faisal, we are very proud to have him tonight, will, as another moderator with me, will be kindly requested to collect these questions, and I, him, and both the speakers will try to answer your questions. Just one of the logistic things here, I noticed that Dr. Shigon is not connected as panelist, and kindly, he is among the attendees. Kindly, Dr. Shigon, if you go through the panelist link that was sent to you in your email, and you join as a panelist, so you can be able to share your presentation. And Ms. Nurhan and Mr. Ala, if you kindly help Dr. Shigon to link and to join as a faculty. Without any further ado, I'll stop sharing and give you the phone to start. Dr. Abu Ragif, share your screen and you start your talk kindly.
Yes. Hello, everybody. Thank you, Dr. Ashraf, for a wonderful introduction and presentation. My name is Mohammed Abu Ragif, and I'm an emergency medicine staff specialist at the University of Uppsala of Sweden. And also, I got the honor to be the chair for the Critical Care Committee for the Swedish Society of Emergency Medicine. Today I have the pleasure to speak about the ultrasound role for determining the fluid responsiveness in an awake and spontaneously breathing patient in our daily practice, actually. Yes, if you all guys look to that number on the right of the box, which is 50%, and I think maybe it will give you some hints, I don't know, to some of you, and maybe not for the others. But the reason behind I put this number is, as Dr. Ashraf said, when you try to give a fluid or a bolus of fluid to your patient who is hypotensive or in shock, so only the studies show that 50% of those patients will actually respond to this fluid bolus that we give them and will get a rise in their cardiac output, while the other of those The other 50 will not even actually respond to this benefit, and you actually put them in a fear of complications, and the complication we're going to speak about later on in the during the session. I usually like to start my talks with presenter cases to get you with me. So imagine that you're sitting like in your ED, as I do, and some of you guys also, if you work sometimes part-time in the EDs, that you have an 80 years old patient that's presenting to the ED, experiencing sudden dizziness and near syncope. And earlier during that day, while he was standing up from chair, he became just lightheaded, felt weak, and then he thought that he was just about to pass out. But he didn't really lose his consciousness. So his family became afraid of that because of his past medical history. So they called the ambulance for a consultation, or maybe take him to the emergency. Ambulance meted him and took some history, and past medical history shows that he has a heart failure actually, with the ejection fraction about only 25%. And he has a diabetes type 2, and he also has an end-stage renal failure, and he goes on dialysis. So when they did some controls, they saw this type of vital parameters, like his soft hypotensive was 78/46, and you see the heart rate, you see the pulse and saturation and the respiratory rate. And what comes in your mind here, like this is the reason of cause of his hypotensive his symptoms, is that he is a hypotensive. So what you do as an intensivist or an ED physician, you grab your ultrasound, POCUS, and you do some cardiac ultrasound, and you go through the cardiac window to do the parasternal long axis view, and you see this image on the left. And what you see actually, just with eyeballing, that you see like his ejection fraction is not that good, and it seems actually consistent with the history that he gave us. So he is in a heart failure. And when you look at the right ventricle, you see sometimes some type of contraction, which is really good. When we do the parasternal short axis, to also confirm your diagnosis, like he has a heart failure, and it's not really compressing that much, the left ventricle. So this is easy. Maybe you saw the diagnosis, you know that his heart or cardiac output is not that well. So the question is like this now. When you go back to the case, he's a hypotensive and he has a heart failure. And the question for us that we do every day, shall we give this guy a fluid or not? Or what do we need to do? And or shall I use one of the modalities that I have? Maybe I give him furosemide, diuretics, I'll give him a fluid, or I give him vasopressor. What usually we go back to pathophysiology to understand the benefit of the ultrasound. What we need to do with these types of patients, we actually depend on the cardiac output we need to know with ultrasound, which we did briefly now. And then we need to know the fluid status in the body, as they are overloaded with fluid. So by the end of my lecture, actually, I want everyone to understand why we give a fluid and why the fluid responsiveness must be assessed with ultrasound before every bolus that we do. And if there's any static indices that we used to do before we use the ultrasound, are they really actual to use them right now? Or we just abandoned them? And why we did that. Velocity and the stroke volume velocity as well are really good when we have a spontaneously breathing patient. So in 2026, the talk that is most focused on is, shall we do another new modalities like a passive leg raising? Shall we depend on the VTI, the carotid Doppler, or the mini bolus testing? And not only responsiveness, we need also to depend on the fluid tolerance. Do my patient tolerate the fluid that I give to him or not? And this I need to do with lung ultrasound and with the venous access scoring, which is used usually by ultrasound. And where is the field is heading nowadays? Do you need to use AI in the future, or automated VTI, or any wearable measures that we can do? And also I will share with you 5 practical bedside ultrasound algorithm that you maybe can use from tonight and how to manage those patients. Go back again to what I told you about the 50% of those people. If we give them fluid without doing an ultrasound for them, they might be benefit by increasing the cardiac output. And this will maybe have its effect for a few hours, and then this will vanish. Once we send them to the ICU, they will not gonna have any profit from that. Other 50 will put them on as a complication, as we said before. We'll get them in a pulmonary edema, and this will increase the longer ICU stay, especially in day 3. The RCTs and most studies said about that, and worsen the acute kidney injuries and bowel and tissue edema, mostly the third space. So, just a little bit of physiology before we go to the ultrasound images. If you look at the graph on the right, just to understand the need of the ultrasound, you see the Frank-Starling curve. And when I peak here, like in the beginning, you see here it goes very steep, and then it will get flattened. So when we go back to the indices here, you have the stroke volume here, and you have the preload. And which means that when the heart is empty, not too much filled with fluid, if you give them a fluid, the stroke volume will increase, but then it will reach a state of plateau. And here comes the role of ultrasound, actually, is to identify the purple in the middle of the curve, not at the end when they are preloaded or they are overfilled with fluid or when they are dehydrated. So here we use our skills with the ultrasound, find those people that are responder, and they will benefit from our ultrasound. As I told you before, when we work in the ICUs or in the emergency department, so we usually depend on some indices, which is the central venous pressure and the pulmonary artery occlusion pressure, the IVCs, and the right arterial pressures. But if you depend on them as an intensivist, they really depend on the pressure, and they not really reflect the volume. So if you have a patient with a CVP of 15, okay, what does this mean? Is the patient overloaded? Is the patient has a stiff right ventricle, or he is on a ventilator, or the patient is on a vasopressor? So you have 4 pathophysiologies. We need a 4 treatment for them. And all of these, the central venous pressure will not gonna guide you. Here comes the role of the ultrasound. If we go back in our studies before, that's what we did, we depend mostly on the IVCs just to measure the volume of the patient. And if you see these pictures, wonderful pictures, you know, this patient, he has a collapsed IVC, mostly below than 10 millimeters. And here you have a very plethoric IVC, which is more than 20. So this is very tricky for us. You know, this patient maybe is overloaded with fluid, and maybe this patient is very dry. So it's very easy. Here you can give fluid, here you can stop giving fluid. But what about the patients in between those? What we're gonna do as intensivists or emergency physicians? And these have our colleagues that have seen many studies. Shall we depend only on the IVCs, or we need to do some dynamic tests? And here come the new development for the recent years to develop the passive leg raising test and to measure the VTI that we're going to speak about later on. As we said, like the topic I'm not going to speak about. This will be my colleague about the positive pressure ventilation maybe, and the stroke volume velocity by ultrasound is very brilliant. But this when you have a really patient on a ventilator, because those patients are breathing mechanically, and you can set their tidal volume, their respiratory rate, and you know they have maybe a regular heart rate. So it gives you a fantastic way of determining the fluid volume of them. But in our case, when you have a spontaneously breathing patient that is awake, this will not gonna benefit us. Will give us only a wrong values, especially when you have patient if he has atrial fibrillation or right ventricular failure. If we go back to this loop, you see this patient's IVCs, and you see it's very collapsed. And maybe you said, okay, I know this patient maybe is dehydrated, so I need to give him a fluid. What we have a problem in determining the ultrasound in spontaneously breathing patient is that when you breathe, the diaphragm, it draws your IVC vertical IVC and give you a false image that vena cava is a plethoric. So this is one of the pitfalls that you might face when you just depend on the IVCs by ultrasound to determine the volume status. Okay, then you say, like, as an emerge or intensivist, okay, what shall I do now if I'm not going to depend on the CVP, if I'm not going to depend on the IVCs, what I'm going to do then? we say like the recent new RCTs and the new studies guidelines, it's recommended that you do both. You do ultrasound imaging plus provocation tests. And the rule of the provocation test in spontaneously breathing patient is to provoke the heart, not the ventilators. And what usually recommended is that you do the ultrasound with to measure the VTI while you test some dynamics modalities. Is one of them is the passive leg raise test for the patients. So the benefit with the passive leg raise is you get reversible 300 milliliters bolus for the patient. It's from the patient's own blood. And the patient lies in a semi-recombinant position, sitting position 45 degrees, and the leg is flat. And you measure the VTI, and all by the sudden, you let them to lie flat. And wait about 1/2 minute, 2 minutes, and then you measure the VTI again. And then you measure it and see. If there's a difference between 10 to 12%, that means that the patient is a fluid responder. You can give them a fluid. The problem is for Sweden, which is related to our GDPR, so we're not allowed to share patients' data informations. So and depend when I starting to learn about the VTI, is I'm gonna sharing it with you just to have like a small. I'm gonna borrow 5 minutes if it's okay, Dr. Ashraf, for you. It's how to measure the VTI exactly. Do like this, and then it's from Dr. Jacob Avila.
But no voice, Dr. Abu Ragif.
Okay, I can explain it for you. Yes, exactly. The goal for the now you hear me, right?
Yeah.
The goal for the VTI is you put the cardiac probe that you use, you put it on the epic 4 chambers for the heart, and you get this image that we usually do. And then what you need to do, you need to get the 5th chamber, which is the LVOT. And then when you are measuring the LVOT there, when you find it, then you can put the velocity Doppler there to measure it. It will make like one horizontal lines below the LVOT, and then you put the other lines that can go perpendicular with the blood flow. And then you measure the angle, and then you can, with the monitor, you can measure the VTI like this. So here's the 5 chambers. Here's one, and this is the 5th one that we usually rely on. And then you make the Doppler velocity will be here. And then you're gonna measure the weights. And if you find like a difference, we'll go back to my slide, just a second. Yes, and if you measure a difference between 10 and 12, then you totally agree that your patient is a responder. But most of the mistakes that we do in the ICUs and in the emergency department, when we do the passive leg raising test, the most important thing is when you do it, you need to do it with the patient's couch, that you bend the whole couch, not only the patient. Because once you touch your patient and you do the passive leg raising test, you will get an activation of their sympatheticus system, and then you will get a false result. So this is the most important, what I usually recommend, like my colleagues to do. And you need to lock your LVOT angle before and after. And you measure at least 3 to 5 beats to confirm it. And then one of the other methods that nowadays is most popular and most easier to do, which is measuring the carotid Doppler, which is the fastest surrogate, I think, nowadays. And the thing that you do with the carotid Doppler is exactly the same way to measure the at the 5 chambers for the heart or the LVOT VTI, but here you do it with a carotid instead. The key for this is once you do your probe, you do the short axis, you identify your carotid here, and then you do just a little bit of pressure to activate that. You know that this is an artery, not vein. And then you're starting to go a little bit backward just to see the aortic valve, the carotid valve here. And then you do the Doppler velocity as well below the aortic, the carotid valve. And then you also measure like the box, and you need to do the line, which is exactly goes with blood flow, and you measure the angle. One of the most important is that when you measure the angle, it must be at maximally 60. In this case, when you measure the angle here, you will see it's 76. So it's not really reliable. So it needs the goal to get the angle of the carotid. It must be less than 60. Other challenges or that we can do instead of a passive leg raising test with ultrasound is you do a mini fluid challenge test. That means like if you do like you decide if you want to do carotid VTI or you do the LVOT VTI from the heart. Then you do the fluid challenge. You give the patient like 100 milliliter bolus, and then you wait about 1 minute, and then you can measure the VTI after it. If you get like 6 or 7% change, this means that your patient is a responder, and then you can give them at least 250 or 500 milliliters fluid. This is a key goal if you have a patient with increase in intracranial pressure, or if you have a patient with pelvic injury that you cannot do the passive leg raise test, or if you have an obese patient or patient on ECMO. So this is you can do. But keep in mind, as Dr. Ashraf said, the fluid or the bolus that you give to a patient is a drug, is not a supportive. So when you give 100 milliliters, it means that you gave him like an extra fluid to those patients. And I just want to clarify something. There's two differences between the responder and tolerance by ultrasound. When you do your approach, when you first examine your patient with POCUS and you see, okay, my patient is maybe is a responder. But the other question that you need to do with ultrasound is your patient a tolerance, can tolerate the fluid that you will give them or not. And one of the two recommendations that we recommend, or all the studies recommend nowadays, is you do a lung ultrasound and you need to do the venous excess ultrasound. The lung ultrasound is very easy. Every one of us can do it. You just scan the 8 zones in the lungs, anterior, lateral on each side, and searching for B lines. If you don't have B lines here, so you know that your patient is a dry, you can give him a fluid. But and you see the very fine and nice A lines, just give them a fluid bolus because this patient can tolerate. I don't mean the patient is a responder, but he is he can tolerate. If you go to see the other lungs, you see the lungs is filled with B lines. We call it the discolites. And this patient is a volume overloaded, and we don't recommend that you give him a fluid. Maybe you can switch to diuretics and vasopressors as a plan. What the studies also recommended that you not only have to rely on the lungs, maybe you can do the venous excess test, is to measure the congestion system of the patients. So you do it in the 4 steps. The first step is you do measure the IVCs as we did before. And if you see if it's like less than 2 millimeters, then everything is fine. Your patient is dry and he can tolerate. But if the patient more than 2 centimeters, then you need to scan them for the hepatic veins, portal veins, and intrarenal veins. And this is also very difficult. If you're not experienced with it, you need to do an eyeballing. You need to scan a lot of patients, and you can scan them and you can grade them to 3 grades. If you see like a little bit congestion, then you say like 1, it's more congested, 2 and 3. And your patient, if it's a 3, that means he's very fluid overloaded and cannot tolerate. So when you want to give a fluid to your patient so you need to scan them with ultrasound. And when you do an ultrasound scan, you need to ask them two questions, and you need to get one of the fourth result. If your patient is a responder with this test, as we said, LVOT carotid, and if the patient is tolerant, as we said, with the lung ultrasound and the venous access. If your patient is a responder and tolerant, then you can give them a fluid. If your patient is a responder and not tolerant, maybe you can give him a diuretics and vasopressor. If your patient is not responder, but is a tolerant, maybe you don't give him a bolus. You need to search for the real problem. And the other one, maybe you have the patient who's not responder and intolerant. In the futures now, I read some few articles now, like they're trying to use the AI in image acquisition, like they want them to really help the people by sounds to guide you to, like, to search for the LVOT, and by voice recorded, they said like scan them, fan them to the right, fan them to the left. This is one of the important development that's going to do with the AI. What the problem that we have when we measure the LVOT is how we get really the VTI tracing there. So I hope in the future, in the next machine, they can do it automatically. So you just like put your you put the Doppler arrays there, and they can measure it for you just like this, and you don't need to do a lot of work. Some studies now, they show maybe in the future, they're going to do a carotid Doppler wearable that you put a patch there on the carotid in order to measure the fluid responsiveness. But I don't know, maybe something in the future. That's what we spoke about. What my algorithm that I want everyone to do when they use the ultrasound is, in order to estimate the fluid responsiveness, first is you need to know your baseline. So you need to scan them, you do subcostal IVC scanning, and then, or you do the LVOT with a carotid. So you know if your patient is dry or not. Then you need to see if your patient can tolerate or not. So you need to depend on the lung, B lines, and the venous access. If the patient congested, there is no idea to do any provocation test. You need to go further. If the patient can tolerate, then you do those provocation tests that I told you, the passive leg raising, or you give them 100 milliliter bolus. And then you measure the VTI, as I said, after 1 minute, after 2 minutes, and see if the patient is responder or not. The practical pills, as I said, half of the patients will not respond, so you need to image them with ultrasound. When we said like the CVPs, it's only a pressure, it's not really reflect the volume. So drop the CVP in a spontaneous breathing patient and use your ultrasound. Use only the IVC when there is extremes, if the patient is very collapsed or is very distended. And if you have a spontaneously breathing patient, I don't recommend that you do the PPV or the SVV. Passive leg raise test, as I told you, you need to flip not only the patient, you need to flip the couch. And you need to wait for 3 to 5 beats. The carotid VTI is very good. I recommended it, especially when you didn't get any good cardiac windows, as well as you need to keep the carotid angle less than 60%. Mini bolus is the tiebreaker, I think, but you need to keep it in mind that the fluid is a medication or a drug. And you need always to check the tolerance without the venous access. And you need to reassess your patient with ultrasound after every bolus that you do. Yes, thank you very much. That was all that I want to share with you.
Great. Thank you very much, Dr. Muhammad Abu Ragif, for this very nice presentation of how we use the point of care in ultrasound in prediction of fluid responsiveness in spontaneously breathing patients. Without any further ado, I would give the mic now to the second speaker of tonight, Dr. Shigon. As I introduced him at the beginning, he is one of the known figures of point of care ultrasound in UK. I had the pleasure to see him and meet him, and he's going to talk to us about the how to predict the fluid responsiveness in mechanically ventilated patients. Dr. Shigon, the mic is yours. You can stop sharing, Muhammad. Okay, great. We see your slides here. You can put it to full screen.
Can everybody see that? Can everybody hear me okay?
Yes, it's okay.
Perfect. Okay. So, thanks so much for the lovely introduction. As Ashraf said, I'm here to talk to you about predictors of fluid responsiveness in mechanically ventilated patients. My name's Shagan. I work in Barts in hospital, and here are my declarations of interest. The main one that's relevant to this presentation is that I have been involved in writing guidelines on the assessment of fluid responsiveness for the Intensive Care Society as part of what's called the FUSIC HD module. So therefore, I already have my own inbuilt biases. And what I thought I'd talk to you about is, first of all, define the concept of fluid responsiveness, talk specifically about how echocardiography and, well, POCUS as a whole can help, but I'm also going to talk about some of the problems and the controversies. So what is fluid responsiveness? The definition, if you look in the literature, is slightly nebulous, but it's basically the ability of your cardiac output to go up by a certain amount after giving some fluid over a relatively rapid period. And that amount of cardiac output and amount of fluid and amount of time varies depending on which part of the literature you read. But most people say 10 to 15% after giving 250 to 500 mils of fluid fairly rapidly over about half an hour. Why is it important? Because we're in the business in the acute care setting of managing shock. And shock comes in 4 different flavors: distributive, obstructive, cardiogenic, and hypovolemic. And ultimately, shock is about supply-demand imbalance. So what is oxygen supply? In particular, when it comes to delivering oxygen and nutrients to the blood, this is the oxygen delivery equation. And it's a mix of hemoglobin plus cardiac output plus dissolved oxygen in the blood. And so what we're trying to do whenever we're managing shock is we're trying to maximize the amount of all of these things that get to the tissues. And one of the things that we can try and maximize is Q, flow, cardiac output. And one way of maximizing cardiac output is to give volume. And that's the reason why we're interested in volume and fluid responsiveness in shock. But before we go into that, one of the things I thought I'd drill down on is try and answer what is this question of volume state? What exactly is the volume state? So many of us remember this diagram from medical school that shows that body fluid compartments are divided into many different compartments. Most of the fluid is intracellular, with a small component that's extracellular, with about 3 liters, well, basically between 3 and 5 liters that are actually located in the circulation. And so what we're thinking about is the circulating volume, and that's usually what we try to expand with our fluids. Measuring this is quite difficult. We can actually measure whole blood volume using radiolabeled blood cells. However, that's quite difficult to do and is normally used as a research tool in ICU, as it takes 40 minutes to do. So what is a shortcut way of measuring volume? One way of thinking about it is to think about the blood as a 2-compartment model. We have a non-pressure generating compartment of blood called the unstressed volume, and we have a pressure generating volume of blood called the stressed volume, which is what actually takes part in our circulation. And you can measure the pressure of that stressed volume as something called the PMS, or the mean systemic filling pressure. And this was described by and mathematically by a fantastic intensivist called Jeff Parkin in the 90s. And these are his words. He describes a mean systemic filling pressure as truly the volume state. And he can use it mathematically to actually create a servo-controlled loop of circulatory dynamics. And he actually did this by using fluids and anatropes to create a closed loop model of the circulation in septic patients. And this model still exists today. You can actually read all about it. So what ultimately I'm trying to say here is you have to remember that when we talk about fluid responsiveness, we're not necessarily just talking about volume state and hypovolemia. What we're actually talking about is the ability of the heart to augment itself and augment the cardiac output by accepting an increase in mean systemic filling pressure. That's really what fluid responsiveness assesses. So fluid responsiveness is not necessarily hypovolemia, and I will come back to this a little bit later. The other reason why we're really interested in this concept of fluid responsiveness is exactly as my previous speaker has spoken about. Fluid is a drug and it causes harm. And here's an example of all of the bad things that fluid can cause. It can cause central nervous system problems, cardiovascular system problems, hepatic system problems. Edema is not just cosmetic. Edema actually is intracellular and interstitial and can cause a huge variety of problems. And a lot of the problems that we see in the critically unwell are due to fluid creep and overzealous fluid administration. So now I'm going to refer to literature, and some of my clever friends have written lots of wonderful papers and about how we can use ultrasound and hemodynamics to assess volume status and give us some clue as to whether or not we should be using fluid or not using fluid. And this is a really nice review written a couple of years ago, featuring lots of superstars of critical care medicine. And one of the ways that has been described for how we can try and assess this quote unquote volume state or the reasons to give fluid responsiveness or fluid responsiveness in particular are to use two different sets of markers, some called static markers and some called dynamic markers. Static assessment of preload, which is again another way of thinking about volume state assessment or a way of thinking about the mean systemic filling pressure. And these use static measurements, so using single point in time measurements. And these include things like measuring the left ventricular end diastolic area, measuring LV volumes, either using visually or using an estimate, measuring the static dimension of the IVC. And you can use advanced techniques. You can actually measure stroke volume using Simpson's biplane with your echocardiogram, or you measuring a velocity time interval, or VTI, which gives you a Doppler estimate of stroke volume. And this is an example of that. So this is a heart where you can see, this is a heart that we would term for people who do POCUS, where you can see that the left ventricle here looks quite empty because it's hyperdynamic and you have what we call the kissing ventricle sign. So if you actually pause this loop and measured and traced an end diastolic area at a single moment in time, that end diastolic area would be small. You can also see a similar thing here with the IVC. So if you pause this image and you try to measure this IVC would be quite small diameter. And these things are potentially correlated with a low preload and with fluid responsiveness. And this patient, on the other hand, has a fixed dilated IVC, despite the fact that they're being ventilated and they're moving quite heavily. So this is what you call a fixed dilated IVC, and this would suggest that perhaps this patient is not fluid responsive. This is the opposite example. This is a patient with a dilated ventricle and a large end diastolic area that would suggest this patient's not volume responsive. And this has all come from that paper. So they've actually given us some lovely numbers. They've given us a left ventricular end diastolic area of less than 10 centimeters or more than as being potentially volume responsive, and of more than 20 centimeters and more than potentially non-volume responsive. And here's the other ways of doing it, slightly more advanced techniques. So on the left, this is using Simpson's biplane, which is Simpson's method of discs involving tracing out LV cavities in diastole and systole, and that gives you a stroke volume. And on the right is using pulse wave Doppler to measure a velocity time integral through the left ventricular outflow tract, which gives you a really, really accurate measure of stroke volume. So these static markers, they seem quite nice, but there are loads of problems with them. And in particular, this paper I would highly recommend that people read. This is a paper called the Chase study, and they looked at static measures of fluid responsiveness and compared that with actual measures of volume state. And what they actually showed is that these static measures do not correlate with the most accurate measure of volume state, which is actually using an indirect method to estimate the mean systemic filling pressure. There was only one method that did, which was actually calculating the mean systemic filling pressure using Doppler-derived cardiac output. And that involves using this calculation using Jeffrey Parkin's formula, something that he derived. So for the most part, I don't think we should be using static markers because I don't think they help us very much. So what about dynamic markers? And dynamic markers are exactly as they say on the tin. They describe using some dynamic aspect of the circulation to try and estimate whether the patient's volume responsive. And these are all based on the principles of heart-lung interactions. So what we know from lots and lots of years of study is that, and we see this in spontaneously breathing patients, but also more magnified in mechanically ventilated patients, is that with mechanical ventilation, when you inflate the chest, you increase the intrathoracic pressure and you decrease venous return from the IVC. And the reverse happens on expiration. On expiration, you suck blood into the chest and you increase flow to the IVC. And at its most extreme, we call this pulsus paradoxus, where you see massive swings in the cardiac output with insufflation and expiration. But on a smaller level, with smaller tidal volumes, without big tidal volumes, and without big swings in thoracic pressure, you can actually see these changes. And these changes are magnified as preload is dropped. So therefore, you can use these tests as a way of trying to predict whether people are volume responsive or not. And so one of the easiest things to do is to find a 5-chamber view and use flow through the LVOT, although you can do this with flow through pretty much any part of the heart of flow on any part of the body. So you can use mitral inflow, RVOT outflow, carotid flow, and what you're doing is you're looking for these for the heart-lung interactions to see whether or not there's a change in the amount of blood and the stroke volume or the flow through these chambers in inspiration and expiration. And this is what that looks like through the LVOT. So I've left a respirometer on here, but what you'd see here is with inspiration, you get this peak here where the peak velocity through the LVOT is low, and with expiration it actually increases, and you get that swing going up and down. This also happens in other chambers and other parts of the body as well. So you can get collapsibility of the IVC with inspiration and expiration. And what you see is that with inspiration, you increase intrathoracic pressure, so therefore the IVC gets squashed, and on expiration, the reverse thing happens. And with the SVC, it's the reverse. The SVC actually distends with inspiration because it's an intrathoracic organ, and relaxes with expiration. And you can get these lovely equations that you can use to try and quantify the change in dimensions of the SVC and IVC with inspiration and expiration. Here are the magic numbers that people have put through lots and lots of research. So if you've got a stroke volume variation of more than 14%, that's highly specific for fluid responsiveness, and if less than 10, it's negative predictive value. If you've got a Vmax variation of more than 12, that's highly positive predictive value. If you've got an IVC distensibility index of more than 18%, and an SVC collapsibility index of more than 36%. These are all associated with volume responsiveness. You probably have noticed that lots of these things have a gray area, and when you have a gray area, you're basically just indeterminates, and you can't really tell you. I would highly recommend reading this paper written by some of my colleagues. That's very useful and gives you lots of these gives you lots of these measures and gives you a nice summary of how to use these measures to assess fluid responsiveness. There's a nice paper written by Philippe Vignon that looked at that compared all these different parameters, and what they found was that aortic Vmax variation gave you the best sensitivity for fluid responsiveness, and SVC distensibility gave you the best specificity. So that's one way to think about it. Just beware that with SVC distensibility, this is a measure that you can only perform with transesophageal echo, or it's only really validated transesophageal echo. You can see the SVC with transthoracic echo, but it's a bit tricky, and you don't quite get the same. You don't quite get the same specificity, and it doesn't work quite as well. There are problems with these approaches. In particular, by relying on heart-lung interactions, all of these heart-lung interactions have been validated in specific settings. The patient needs to be in sinus rhythm. The patient needs to have a regular heart rate. They can't be bradycardic or excessively tachycardic. They have to be mechanically ventilated, and they have to be mechanically ventilated at a tidal volume of at least 8 mils per kilo. They cannot have raised intra-abdominal pressure. They cannot have an open chest, and they must not be spontaneously breathing. So they have a very narrow limit, a defined limit of range of ways in which they can be used accurately to detect volume responsiveness. And I would highly recommend reading the study by Majub et al., where they did a point prevalence study in an ICU of about 300 patients, and they looked to find which patients actually fulfilled all of those validity criteria. And on a single spot prevalence, they found only 2% of ICU patients at one time fulfilled those criteria. That's a little bit of something humbling for us to think about. Another humbling paper to read is this paper by Scott Millington that talked about ultrasound of the inferior vena cava for fluid responsiveness. Whilst it's a great idea and it's a lovely idea in principle and it's a nice, easy organ to get to, there are loads of problems with using the IVC because it's affected by not just volume responsiveness and intrathoracic pressure, but loads of other things, right? Atrial pressure, intra-abdominal pressure, and lots of other problems. You have to be wary of it. So one way that people try to think about of these dynamic challenges on using heart-lung interactions is try and magnify them and try and increase their specificity. So Sheila Matra and Xavier Monet and Jean-Louis Taboul came up with this idea of the tidal volume challenge. So most people are ventilated at 6 mils per kilo, so why don't we just increase the tidal volumes to 8 mils per kilo, and therefore more of these people will then satisfy these requirements for accurately assessing this. So the tidal volume challenge is just increasing the tidal volumes up to 8 mils per kilo for briefly to magnify your heart-lung interactions and identify the patient's volume responsive. Another test you can do is something called an end expiratory occlusion test, and that basically involves, exactly as it says on the tin, occluding the ventilator and in end expiration for 15 seconds, and that magnifies your heart and lung interactions and will increase your swing and your variation and allow you to identify volume responsiveness. And they can work quite well. They just have to remember that what you're doing is you're basically doing an expiratory hold, so the patient needs to be relatively hemodynamic stable and able to tolerate it. Which brings us to the real gold standard, and exactly as it is in spontaneously breathing patients, it's a passive leg raise. A passive leg raise is pretty much 99% sensitive and specific for picking up fluid responsiveness, and that's basically because it's a mini fluid challenge that's all contained within it's a reversible fluid challenge that's contained within the body. All you're doing is you're tipping the legs up, and you are recruiting about 300 mils of unstressed volume from the legs back into the general circulation, and then you're using that as a reversible fluid bolus. And when you tip the patient back up, it redistributes, and so therefore you've given fluid without having to give fluid. And this works really well. It's really sensitive, it's really specific, and it's the gold standard, and so just do that. What you need is a really accurate cardiac output monitor to detect the changes in cardiac output when you do this, and echo is actually very good for this. You just use your LVOT VTI with your echo, and it works really well. The key number here is a stroke volume increase of more than 10%, or VTI increase of more than 10%. But here's the problem. Fluid responsiveness does not mean the patient needs fluid. So this is a lovely study, one of my favorite studies, that shows that about 50% of people walking around who are completely physiologically normal and are not thirsty would actually count as fluid responsive if you did a passive leg raise. Which brings us on to this idea of fluid tolerance and safety. So if fluid responsiveness has loads of problems, why don't we use fluid tolerance and look for fluid stop points? And here are some examples of fluid stop points. That's just my alarm telling me that I'll finish. I'll aim to finish in the next couple of minutes. And here are some examples of things that we can use for fluid tolerance. So we've already talked about lung ultrasound, looking for increased extravascular lung water. So on the right, we've got normal lung, and on the left, we've got B line suggestive of increased extravascular lung water. You can also use lots of echo parameters to assess high left atrial pressure. And here are some of those parameters. You can use the inflow velocity through the mitral valve. You can use tissue Doppler of the mitral valve annulus, E prime, and you can use tricuspid Vmax. And these things give you some ideas that perhaps the left atrial pressure is raised, and therefore the patient is likely to get pulmonary edema. You can use things like the IVC and the portal venous Doppler, which are all components of the VEXA score that we've talked about. And the VEXA score is basically an index of raised right atrial pressure that tells you that perhaps the patient is going to be volume intolerant. And this is a lovely paper that kind of describes that situation. But there are problems with this. And my big problem with looking for volume tolerance is by the time you find the patient's volume intolerant, it usually means you've given them too much fluid. So the horse is already, you're trying to shut the stable door after the horse has bolted. And this paper very nicely illustrates this. So exactly as the previous speaker said, volume intolerance or fluid volume intolerance and volume responsiveness can coexist at the same time. So you can have people who are volume responsive and volume tolerant, and people who are volume responsive and volume intolerant, and they all exist in different parts of the spectrum. And that's a really important thing to understand. So I love this slide. We like to believe that we give people fluid and we get them fluid responsiveness, and we're fluid responsiveness until one day we suddenly become fluid intolerant. But in practice, what usually happens is that people are fluid intolerant long before they become fluid responsive, and they'll continue to be fluid intolerant after while they're still fluid responsive. We have to remember that we need to go to option D. We need to think about a personalized scenario in fluid and in critical care, and how we tailor fluid to people who have a varying spectrum of fluid responsiveness and a varying spectrum of fluid tolerance. So we need to reassess these things constantly. And that brings me to the end of the talk. So these are my conclusions. Fluid responsiveness really reflects the ability of the circulation to handle an increase in mean systemic filling pressure. And by far the most accurate way to do this in a mechanically ventilated patient is to do a cardiac output before and after doing a passive leg raise. But just remember that because a patient's fluid responsiveness is responsive doesn't mean you need to give them fluid. Echo may be useful to assess fluid responsiveness, but it must be integrated with good history and clinical acumen. I think personally, echo is probably more useful to tell you when not to give fluid. And when you're in doubt and you're not sure, just put the probe down and just be a doctor. Just look at the patient and look at the fluid chart and do something sensible. And thank you so much for your attention.
Great, as usual, Shigon. Very nice presentation. And we are now open for the question from the fellows. Dr. Hisham, if you have a question to Shigon and Muhammad.
No, it was crystal clear to me.
Okay. So I can see some questions here, Hisham, in the Q&A, the section. So Juhub Hassan is asking, in CKD patient with acute heart failure with suspected septic shock with inosarca, what fluid should we give if we assess that patient and we see that he or she has an intravascular hypovolemia, who can start answering? Shigon or Muhammad? Let's
Yeah, it's
start.
okay. Yeah, absolutely. I can take it. These are very sensitive group of patients when they have chronic kidney diseases and also they have a heart failure. So what's the sepsis guidelines recommended is you go early with vasopressor as much as possible and as soon as possible. But if you want to give them a small amount of fluids, what I usually use with those patients is an isotonic, which is a ringer acetate or plasmolite. I usually sometimes avoid the normal saline for the sodium, which would not say that it's not really kidney or renal friendly. So I usually go with plasmolite and ringer acetate. And as soon as possible, I will go in with my vasopressor. I know if Segon and my other colleagues do the same. What do you think?
What do you think, Shigon?
My answer to this is quite controversial. So strictly speaking, so if this is the patient that we describe as being intravascularly dry yet volume overloaded. And if you look at the actual physiology of the revised Starling equation based on the glycocalyx and what we know about fluid creep, that is technically not really possible. What you have, so if the patient has edema, unless they have something like Clarkson syndrome or elephantiasis or lymphedema, by definition, if the patient has some kind of edema, they are volume overloaded. So what you are describing is a patient who has edema but is hypotensive. And that is a different kettle of fish. It does not mean that it doesn't mean that they're hypovolemic. What it means is that they basically have a low, or what it means is that they're hypotensive for different reasons. So the things you can do really are give them noradrenaline, and I probably wouldn't give them any fluid.
Yeah, sometimes we see, and this is one of the common fallacies of the using IVC in an abdominal distended abdomen with increased intra-abdominal pressure or compartment with the ascites or associated other findings that makes the intra-abdominal pressure high, that you might see the IVC collapsing or smaller than what you expect, and then you believe that this is intravascular depletion. A golden rule in point of care ultrasound, and this is a program for point of care ultrasound, is you never rely on one item or one thing to conclude for the findings. So if you suspect in such kind of an ASARCA patient that they are intravascular depleted, and you are examining only the IVC, you should not do that. Go to the right ventricle, left ventricle, try to collect data and respect, as Shigon said, the history and clinical presentation, of course. And giving fluid to those who are with systemic congestion will make them worse. So the decision to give fluid for such kind of patients, relying on only one thing to investigate or diagnose presence of hypovolemia, is, in my opinion, critical. So I have a question to Dr. Shigon. In case, and this is a question from the fellow here also, in case you have to choose in a busy environment to choose only one or two parameters to go and decide if your patient is having fluid responsiveness in mechanically ventilated patients, what best parameters you advise your colleague or your fellow in ICU to do?
There are only two. First one is a passive leg raise. Second one is give a fluid bolus. Those are by far the two most accurate ways of doing it.
But then when you give the fluid bolus, you have to have a continuous output, cardiac output monitoring, or a VTI change if you are confident that you are measuring it rightly.
Absolutely. And so if you look at all of the data, using LVOT VTI correlates with nearly 99 to 100% sensitivity and specificity to measuring cardiac output using the gold standard of PA catheter. So if you learn how to do it properly, which means getting a 5-chamber view, zooming it, making sure that you get your Doppler gate right on the aortic annulus, where you get an opening click and not a closing click, making sure that your sweep speed is 100 millimeters per second, and then accurately tracing it. Then you will have a really, really accurate cardiac output monitor that's actually very sensitive to detect even small changes in cardiac output, which is why a passive leg raise or giving a fluid bolus and measuring your VTI before and after is by far the best way and more sensitive and specific way to do it with POCUS.
Yeah, back again to the concept, which is if you have hypotensive patient, then you ask the question, should I give or not to give fluid? Then you may test your patient. But if you have, because we see this commonly also, if you have hemodynamically stable patient, there is no point to measure anything. And if the things are straightforward in favor of hypovolemia, then you probably need nothing to give your patient fluid. But in query cases, or when the question is not that clearly answered, that to give or not to give fluid, this is the type of patients that preferably to do with point of care ultrasound. And it was found to be not, at least not inferior to the semi-invasive or invasive methods of predicting the fluid responsiveness. Dr. Abu Ragif, if you kindly recommend, as Sigon did, a simple test to do with point of care ultrasound in resuscitation room or in emergency to predict the fluid responsiveness and
I totally agree with Dr. Segon. Passive raise and fluid bolus, those two.
Good, good, good. And again, you know how to do the VTI as only VTI, because if you go back to the equation, stroke volume equals VTI times area, and the area is fixed or stable, so VTI is a surrogate of stroke volume. Go ahead, Dr. Abraham.
Just to add something, because I have some discussions with my colleagues also in the ED, because we work a lot. We have a very busy emergency department. So most of my colleagues, we don't have really time to do the VTI and do the fluid responsiveness test and stuff like that. But actually, those type of patients, they are not very common that they visit your ED like every day. Maybe you meet those patients. From my point of view, you maybe have like at least maximally 2 or 3 patients a week. So it's really worthwhile, because if you do it right, you measure the fluid responsiveness for them and you give them the adequate amount of fluid if they need, or you go directly to vasopressor if they are overloaded. You will absolutely save them from the ICU stay, you save them from the hospital stay. So it has benefit. The early resuscitation is a big deal, I think, from the ED point care of view. Yes.
Thank you very much, Dr. Bragiev. Thank you, Dr. Shigon. Do you want to comment or add anything, Dr. Hisham Faisal?
No, I am just answering some of the questions online.
Go ahead.
But I would like to say, usually in reality, what's happening? Patient come to ER, hypotensive, fluids would be given already. So it is very important to have a second thought. Okay, this patient have received fluid. Do I need to give more fluid? Or no, he's full now. Or is he's already deteriorating with this fluid, and maybe I need to take out fluids. So this is what really the POCUS would help you with this decision. Is this patient now is congested? Already he had received, because this is what usually happens. Patient coming hypotensive, give fluid. This is what any junior doctor would do in ER, and this is like a reflex reaction. So you need to, after to seeing for the second time and for assessing what happened with this patient, this is where the POCUS will be of great help to assess.
Thank you, Sham. Dr. Zanera is asking a very interesting question, and I see Shogun is answering her in writing, but I would love if everyone hear you answering this question, Shogun. If there's disagreement between the POCUS finding and your clinical sense or examination, which one you believe more?
That's a really interesting question. I think it's not really a matter of what you believe, it's about recognizing the limitations of all of them. So clinical examination, the data on clinical examination for assessing volume state is that it's actually really quite poor, except at extremes. So all of the usual things that we think of, dry mucous membranes, et cetera, et cetera, et cetera, are not fantastic. They work really, really well if people are, profoundly dry or profoundly volume overloaded, but there's a big gray area. POCUS is great, but as I've mentioned, POCUS has lots of limitations. You have to recognize the limitations: open chest, intra-abdominal compression, pressures, mechanical ventilation, et cetera, et cetera, et cetera. When I'm not sure, get more information. And there's lots of other ways that you can try and work out whether or not your patient whether your patient will benefit from volume or not. You can use things like your metabolic status. So hyponatremia and hypernatremia are actually quite useful for me. Hyponatremia can help tell you if the patient is profoundly volume overloaded, if they've got a dilutional hyponatremia, as you see in heart failure. And hyponatremia we often see from patients who are profoundly volume overloaded because we give them too much salt. And the clue there is they have a high sodium and a high chloride. So both of the patients for me will get diuretics. The people to be wary of, the people who are hypernatremic with a normal chloride, and then you think, oh, right, they are actually dry. Use things like urea, creatinine. You can get body weight, do other things like that. And you can also then, if you're really, really not sure, put in a formal cardiac output monitor. So I have access to PA catheters, so I'll put a PA catheter in and get an actual number. That's the gold standard. You can use a PICO. So ultimately, what I'm trying to say is, when you're not sure, get more information, and you can use that information to help adjudicate. One really, really important one that I haven't mentioned: if the patient's awake, ask them if they're thirsty. Thirst is an incredible volume state monitor and is one of the most accurate ones that there is. So if they're not thirsty, don't give them volume. If they are thirsty, then give them a glass of water to drink, and they will regulate their own volume.
Great. And again, one of the big advantage of point of care ultrasound that makes it maybe head-to-head to all other tools is that when you move around with your probe from one area to another, you get a visual assessment of the central circulation, which is the heart. You see the right ventricle, left ventricle, right atrium, left atrium, IVC. If you are there with the TE probe, you see the superior vena cava. And seeing the heart is much better than hearing about the heart. So you may see and discover a lot of things that is assuring. If you see, as some of the images shown by Shigon and Abu Ragif, a very dilated, does not globally contract well left ventricle, does this ventricle or this circulation needs more fluid, or most likely a back pressure to the RV and systemic venous congestion will be eventually there. And giving fluid to such kind of patients will deteriorate them. So the point of care ultrasound is essential in every hemodynamically unstable patient. In less than 30 seconds, Dr. Abu Ragif, because this is a common question being asked everywhere in acute care settings. Is it time consuming or time saving using point of care ultrasound in ED department?
Well, it's time saving because since I'm speaking from Sweden and most of the European countries, our ED is crowded. We have a problem with the crowding, and a very, very long time waiting for imaging like X-ray, CT scans. And if you just put the probe and if you just take 1 minute or 2 minutes extra, it will save hours of waiting for further diagnostic methods. So I would say absolutely it's a time saving.
In ICU, Dr. Shogun, do you see it time consuming or time saving?
Depends on the patient. If it's a straightforward patient, so I see a lot of post-op surgical patients. For them, doing POCUS on each one of them for volume assessment's a waste of time. They're awake, they're extubated. I'll just ask them if they're thirsty. Once the patient is sick, it's massively time saving, because every drop of fluid that I can stop giving a patient will translate into benefits days or weeks down the line, when the patient is not edematous, not delirious, hasn't got congestive renal failure and congestive liver failure, and has managed to avoid the filter because I've stopped volume overloading them. So those kind of things are really useful.
Great. And we have to know what to do, how to do. This is very, very important for all of us in critical environment. Without further delay, I would give the mic now and the chance for one of our fellows to present an interesting case. And as we said, one of the purposes for the live webinar is to bring your cases, bring your questions, and we are here to see and discuss and we share knowledge and experience. It's my pleasure to introduce Dr. Shamin Wirisikara, and he's a consultant intensivist in Telford Hospital in UK, and Shrewsbury and Telford Hospital in UK. Floor is yours, Dr. Shamin. Please go ahead and share your screen.
Thank you for the kind introduction, Dr. Ashraf, and I would like to thank you for the kind opportunity, and I'm very grateful for your dedication which we have seen during the past 4 months, and I would like to thank all the faculty members for their excellent teaching. And this is a case which I encountered last month. I work in a district general hospital in UK, so I'll go ahead. We encountered a 33-year-old female who had a background history of tricuspid valve endocarditis, and she had undergone an anterior tricuspid leaflet and patch reconstruction in 2024, and she has had an annuloplasty ring. She had completed treatment for hepatitis C, and there was a history of being an intravenous drug user, and despite the previous endocarditis, she has stopped using intravenous drugs. And as per the history, the last use was on admission. She was hypoxic, hypotensive, and she had deranged investigations. I'll show it later on. And as per the standard treatment, she was initially put on 15 liters oxygen via non-breathing face mask. She got about 2 liters of oxygen. She had a history of penicillin allergy, so they gave IV vancomycin after they saw the chest X-ray. So the bloods were these. Sodium was slightly low, potassium was high, and she had evidence of ongoing AKI with a urea of 28 and creatinine of 234 and a estimated glomerular filtration rate of 23. ALT and bilirubin were raised, but albumin and ALP was normal, and she had a markedly raised INR, which was 4.1. White cell counts were elevated, 33, with a neutrophil leukocytosis. Hemoglobin was 117, and she was thrombocytopenic, and she had a raised CRP, which was 307. And the next day, actually this was the next day, the blood cultures showed that it has grown gram-positive cocci. So this was the chest X-ray which was done in ED. They haven't done any POCUS at the ED, not a chest X-ray, and they had not done a bedside echo. So in this chest X-ray, when you look at it, you might appreciate that there is some shadowing in the left basal area with obliteration of the left claustrophrenic angle. I'm sorry, the X-ray is not very clear. So she was escalated to ITU because she was not responding to fluids. Despite receiving about 1.52 liters of fluids, she was hypertensive, and she was initially started on metronidazole, then came to ITU, had a CVC, was started on NORAD, and she was started on high flow oxygen as well. So given initially the working diagnosis was a community acquired pneumonia, because there was evidence in the chest X-ray, and the history was suggestive. So initially she was managed as I said, community acquired pneumonia. So after she came to ITU, given her history of previous IVDU, ongoing IVDU, and previous infective endocarditis, we thought that we should get a 2D echo to rule out IE. In the ITU, we did a point of care ultrasound. Initially did a chest ultrasound which showed this. So I'll quickly play the images. So these were the findings, and this is the left side, and this is another image on the left side. So when you see the ultrasound images, what would you think of it? Is it a left sided pleural effusion? Is it a left side consolidation? Is it left side atelectasis? Is it left side pleural effusion and atelectasis? Or left side consolidation and pleural effusion? What do you think of it?
You can share in writing in the Q&A or chat area if anyone interested.
In the interest of time, I'll play the diagnosis. So this is the left side. As you can see, this is the spleen, which I'm showing from the pointer, and this is the consolidation on the left side, and there's a big pleural effusion as well. Apart from that, if you can appreciate that there are fibrous strands. I play it again. There are like worm-like things pointing from the edge of the consolidation. So the X-ray showed X-ray revealed that it might be a consolidation, and it showed that there was evidence of effusion by the obliterated costophrenic angle. But unless you had done a ultrasound chest, you might have missed it, that there's a big pleural effusion and a nice consolidation and fibrous stranding. And these are the echo findings. I have not shared all the findings, but I'll share some of the important ones. This is the parasternal long axis view. As you can see, the RV and LV are contracting well. The LA is slightly enlarged, and the mitral valve and the aortic valve are opening well. And in the next image, I have put color across the aortic valve, and can't see obvious regurgitation. Then I have put color across the mitral valve, and across the mitral valve also can't see much regurgitation. Then this is the inflow view of the right side. On the top you have the right ventricle, and on the bottom you have the right atrium, and as you can see, there's a large vegetation which is literally obliterating the inflow of the right ventricle. So I have put the answer as well. So if you see this type of large vegetation, and you must think about the consequences of the pathology. So if there's a big vegetation sitting on the inflow of the right ventricle, since the valves will not be closing properly, you can get a torrential TR, severe TR, and there can be obstruction to the venous return, because from the right atrium, the right ventricle will not be filling properly. And because of that, because of the poor venous return to the right side, ultimately you will get less venous return to the left side, and you can result in cardiogenic shock. And there's a result, and the other consequences, you can get pulmonary embolization. The vegetation on the right side can shoot up into the lung, and apart from pulmonary embolization, you can get lung abscesses. The other important thing is, if there's a right to left shunt, you can get embolization effects due to the vegetation crossing the heart from the right side to left side. If there's ASD or maybe patent foramen overlay. So luckily this lady didn't have any shunts from the right to left side. And these are some more images of the vegetation. So this is a parasternal short axis view at the level of the aortic valve, and at the tricuspid valve you can see the vegetation clearly. And this is a close-up view of the vegetation, the same view. Again a close-up view. And this is a view of the right ventricle, a focus view, and the right atrium. So as you can see, the vegetation is literally obliterating the inflow of the right ventricle. And as you can see, the right ventricle function is slightly reduced. I measured the TAPSE, it was around 1.5. And this is a view which shows where I have put color across the tricuspid valve. In this patient, surprisingly, the patient didn't have a torrential TR jet, tricuspid regurgitation jet. There was a mild jet, but it was not very significant. Just did the left ventricle as well, and this is a focus view of the left ventricle. As you can see, the left ventricle is contracting very well. And this is another view for the left ventricle, two-chamber view. As you can see, the left ventricle is contracting very well. So in summary, the findings of the echo were there was good LV function, RV function was slightly reduced, and there was a large vegetation sitting on the tricuspid valve, which was obliterating the inflow of the right ventricle, and there was no significant tricuspid regurgitation, and couldn't see a left to right to left shunt. So those are the summary of the echo findings, and apart from that, in the ultrasound there was a big left-sided pleural effusion and a consolidation as well. So in ITU, this is the management. Initially I told that in the blood cultures there were gram-positive cocci, but subsequently we found that there was Staph aureus growing on it, and we got the microbiology advice and changed the antibiotics from vancomycin to daptomycin and fosomycin to cover the Staph aureus. So during the stay, her oxygen requirement gradually increased. Initially she was on high flow, it went up to 80%, and the double strength NORAD requirement also went up, and apart from that she got a worsening metabolic acidosis. So during the stay we tried to avoid intubation as much as possible, given the fact that if we intubate, the effects of IPPV, especially tidal volume and PEEP, would further compromise the right side venous return. But ultimately she was getting more drowsy, and as I said, the oxygen requirement was going up, then we had to intubate. But surprisingly, after intubation the oxygen requirements were static. They actually came down to 40%. But because of the metabolic acidosis and worsening acute renal failure, we had to start her on the filter, and we started on CVVH. And we also did a CT head just to exclude any effects of embolization, and the CT was normal. So in the ITU, the vasopressor requirement went up, so we stick her on a cardiac output monitor in LIDCO. She showed a reasonable cardiac index, which was surprised, although there was obstruction of venous return, and she showed low systemic vascular resistance in keeping with the septic shock because of the infective endocarditis. So we had to start on vasopressin to address the low SVRI, and she developed further hemodynamic deterioration despite addition of vasopressin, and we did a few tests to see for fluid responsiveness and vasopressor responsiveness. So the passive leg raise didn't show any response, which meant that she didn't need more fluids, and we did a vasopressor challenge, and because of the vasopressor challenge the cardiac index worsened, and the AKI and the anuria worsened. She kept on increasing her lactate despite being on the filter and the worsening acidosis. So initially the case was discussed because we thought that this is a case that should be addressed in the cardiothoracic center, but given the fact that she had multi-organ failure and gradual deterioration, they decided that she is not fit for surgery. So ultimately what happened was she was palliated, given of the poor prognosis and not being suitable for surgery. And these were the take-home messages for me. So first and foremost, we have to have a high degree of suspicion for infective endocarditis in the context of risk factors. So ideally, someone should have at least kept the probe on the chest and seen an obvious vegetation would not have been missed if it had been done. And it also shows the importance of point of care ultrasound in the management of critical ill. The other thing is when we see a large vegetation, we should take into account the pathological effects, and then as per the effects we should manage the patient, like doing a head CT to exclude embolization and the other things which are done. And apart from that, if you see a significant vegetation, the patient should be in a place where the patient should be managed optimally, but unfortunately in this patient we couldn't do that. So that's all I have to say, and if you have any questions, I'm happy to take. And thank you, sir, for giving the chance again.
Thank you very much, Dr. Shamin. It's a really interesting case. And let's conclude with the question to the panelists here, particularly Dr. Shogun and Dr. Hisham Faisal, because they are both working in cardiac centers. Don't you think that this patient would be better referred to cardiac surgeon the earlier the possible from the ED when they discovered presence of vegetation on the valve obstructing the right side pathway?
I was about to say this. Currently, we had a patient, a similar scenario, who had infective endocarditis with large vegetation on the mitral valve. And he was failing the antimicrobial treatment. And this is one of the indications of surgery. If you have a patient who had failure of antimicrobial treatment in infective endocarditis, so source control in such patients is very important. In our patient, because he was quite young, he was 33 years, we have to push the surgeon hardly to take him while he was intubated, while he was in multi-organ failure. And we know that post-operative he will be in very poor situation. And he came out on ECMO, but this is what's happening. For 24 hours, it was very horrendous course. Today, we explanted the ECMO, and patient is awake, is still intubated, but surgical treatment in such patient is very important in early, before he get much worse. And of course, it have to be the decision of the surgeon, but really, sometimes you need to screw them.
What do you think, Dr. Shegan? Thank you, Sham.
It's always worth doing these things. I mean, we never know what would have happened. We can't say. I mean, I think the team did the best that they could, and we can't say that a referral to a surgical center would have changed the outcome. But it's always worth trying to do the absolute best for your patients. It's quite important to get them to tertiary centers because there's lots of options now. So particularly for tricuspid vegetations, there are semi-invasive options using kind of like vacuum seals or vacuum devices on the right side where you can basically just suck up the vegetation without doing a stenotomy. So potentially that could have helped, but we don't know. So all I can say to Charmin and the team is you did your best. And yeah, wherever possible, other people will try and help.
Thank you, Shamin. Shamin, can you elaborate more the reason why not to refer this patient earlier and the reason they refused her later because of the multi-organ dysfunction and possibility not to make it? So what was the reason, and would be the decision change if it was referred earlier?
She was actually referred, so she had
before intubation, I mean.
Yeah, so she didn't have echo in ED. Once she came to IT, she had the echo and we made the diagnosis. On the same day we referred, but since she was in multi-organ failure, they didn't want to accept the patient, given the fact that she was coagulopathic, she was thrombocytopenic, and she had ongoing AKI. So before intubation, although we referred, they felt that she's too sick to undergo surgery, and she has to manage the patient with antibiotics in our center. That's what happened.
Thank you again. Thank you very much. It was very interesting and very nice meeting all of you tonight. I repeat thanking all of you, Dr. Shigun, Dr. Muhammad Abu Ragif, Dr. Hisham Faisal, Nurhan, and Ala, and from ICOM, and of course, Dr. Shamin, and everyone attended tonight. Thank you very much, and see you in the next webinar. Bye-bye.
Thank you. Bye-bye.